Powerful testimony as we delve into this study looking at mental health in young women and how do we close these gaps. Very nice to see my friend Dr. Rakesh Jetley here as a witness. Rakesh, great to see you here. I know you have a wealth of knowledge that can really help this committee and help the federal government make better policy decisions to help our youth and mental health. My question to you, and you've talked about this and you addressed it in your testimony, Dr. Jetley, is we have this great movement where our youth are more comfortable asking for help. They've sort of, the stigma, we've done a lot of work and it's paid off, but when they go to get help, there's nothing there. The resources aren't there. What's your suggestion on how we close the health equity gap?
Well, thank you very much for the question. It's a huge question. My colleague just mentioned what is not the answer, which is to continue to prescribe medication without psychotherapy, without counseling, and let's just give these kids some stimulants and antidepressants. That's probably not the answer. I think realistically, we have to reconsider how we provide care. And that's something that we've struggled with over the years. The idea that every single person that has a psychological difficulties or difficulty fitting in is going to have access to a one-on-one psychotherapy once a week for 1 hour for 6 months, 8 months probably isn't realistic, even if we resort it. So I think leveraging technology is one of the ways to do it. I think developing group-based therapies. There's different kind of platforms that have been developed, like for cognitive behavioral therapy for insomnia, where one clinician can be magnified and see 12 people a week instead of 12 people an hour, instead of that. So I believe it's multimodal. I think it's education. I think there'll be resources in more programs. I mean, clearly the very, very ill, the eating disorders are going to need sort of hospital beds and things. But I think that general wave of mood and anxiety that we're seeing, people are going into walk-in clinics or seeing their family doctors, they're getting prescribed meds and they're not really getting help. So, it's not a great answer, but I think that we really need to rethink about how we structure access and really get away from the traditional model of this one-on-one psychotherapy for everybody.
Thank you for that, Dr. Jetley. And I think, we know we have a labor crisis across this country, and frontline workers, yourself, psychiatrists, psychotherapists, counselors, doctors, they're not immune to this labor crisis. They're not immune to the burnout. And the demand is so high for people needing help as we see these increased rises of depression, anxiety. We need more access to counseling. How do we protect you? How do we protect the frontline workers from burnout? How do we close that gap and meet the demands of those who are asking for help, but also protecting the frontline workers?
Yeah, I think those are incredibly difficult questions as well, because we have colleagues that are working 60, 70-hour weeks, working till 10 o'clock with a patient in crisis. Most of us that are in practice don't turn our phones off, which probably we should. So trying to balance the work and what we know about burnout and depression in our own professionals and provide the care. So I really think the boost in the care available, I really believe in leveraging technology, having team-based approaches to care, because I think too often the burden being on one clinician probably isn't a great thing. So I'm a firm believer in team-based approaches and finding the efficiency of finding the right professional for the right person when there's time. So clearly we need to educate and protect our frontline workers, be they mental health or otherwise health workers. But that's not going to necessarily address the gap. The gap has to be addressed with probably an increase in funding, but then finding an efficient way to use that funding, not just continue to throw resources at a problem that's struggling.
Thank you. Thank you, Dr. Jetley. One of your sayings, I see one of our witnesses has their hand up.
Peter, did you want to add on to that question? Is that what it was? You wanted to add on to that? Okay.
Yes,
Michelle?
Madam Chair. I don't know if I just have a minute. I just found the question very interesting, and there's just this point about the burnout, because I think a lot of healthcare professionals, including myself, may have experienced some level of burnout in the past few years. But one thing, and I've thought about this quite well, and I was just listening to Dr. Rakesh when he talked about us not turning our phones off, which is what most people do. I just came back from vacation, and every time I'm on vacation, I find that my phone is constantly on, especially from colleagues who I'm looking after their kids. And I find that it causes a lot of stress. From like, it's easy to turn our notification that we're going to be away when it comes to email, but for phones, you can't do that. What I think we should really start talking to medical students, because there are a lot of mistakes that we made that we cannot, it's hard to undo now when it comes to boundaries. So for me, the big message is boundaries and learning from the onset about protecting one's, being mindful about those boundaries. Because for a lot of us, especially when I started, I was like, okay, other healthcare providers, you do anything to support your colleagues, but then when there are no boundaries, and then I find that there's that domino effect and we end up burning out, and it's hard to now tell the same people to say, please don't do this at this time. So I think at this point, that could be one of the things that we could looking at medical students, that when they start, they shouldn't make some of the mistakes we made.
I'm gonna direct this again to you, Dr. Jetley. We had a UNICEF report came out in 2020, and it is really shocking and upsetting. Canada ranked 35 out of 38 in top rich countries. Use air quotes there, like rich countries is their definition, and we were 35 out of 38 on their report card of highest rates of teen suicide. Why do you think we are getting so much worse when we're supposed to be this great country?
Well, I mean, I think it goes to going back to the whole holistic society thing, well-being, social supports, connectedness or disconnectedness of society. From a treatment perspective, when we have the lack of access to care, I mean, a lot of times social things, but there are kids that become depressed, that become psychotic. I mean, it's abysmal. I mean, in my city, Ottawa, it's a year and a half to wait for a psychiatrist for a teenager, right? And I mean, I have kids that age. A year and a half is a lifetime at that age, right? So I just think that, again, it's that need care gap, and so they'll go to the emergency room time and time again, and eventually they'll complete suicide. So I think it's the whole thing, from the societal thing. We talked about bullying, we talked about these things, and safe place, raise help, care by the paraprofessionals. But then that acute suicidality needs sort of urgent psychiatric care sometimes, and we really don't have that. I mean, we can talk all about universal health care if we want, but the reality is it's abysmal how long kids have to wait, and that's why my colleagues are phoning me and asking me for help all the time.
It's true. Those are staggering statistics, and you said it really well. The other thing you said that I thought was really powerful was you said social media is traditional bullying on steroids. I have barely any time left, and I'm going to direct this to Dr. Peter Adjuze. I don't know if I've said your name right. When we talk about eating disorders, I'm curious if you believe that an eating disorder, if there's data or research to say that an eating disorder is a symptom of trauma.
You've got about 20 seconds, Doctor.
Okay. Well, okay. Definitely, there are connections between eating disorders and trauma. Specifically, I know eating disorder is a big umbrella term. We have anorexia, you have bulimia, you have binge eating disorder, you have avoidant restrictive food intake disorder.
I'm going to help you out, Peter, here. I'd say yes. And most patients with eating disorders have a history of trauma. Not all, but sort of like the numbers like borderline personality disorder, you're talking 80 to 90%.
Awesome. Thank you so much. I know we've got so much more information.